Hi guys, so today we're going to talk about the thorax and the lungs, and I want to cover a few points in this video. So firstly, I want to go really briefly over the basic anatomy and physiology of the lung, which I know we all know at this stage of medical school, but I'm going to go over it really quickly anyway. And then I want to talk about the most common concerning symptoms regarding pulmonary medicine, so like chest pain, dyspnea, and things like that. And then I want to talk about health promotion, so like screening, immunizations, tobacco cessation programs, and stuff like that. And then for the last bit, I want to go over the techniques of examination, which I probably would do as a separate video because that's going to be quite long. So that's going to be about the inspection, palpation, percussion, and auscultation of both the posterior chest and the anterior chest. So for this video, I'm gonna, talk about just the introduction and just the theory behind thorax and the lungs. So I know that we all know how to count intercostal spaces in the ribs, so I'm gonna skip over that part, and I'm just gonna mention really briefly, like we have special landmarks that we need to remember. And these landmarks are special sites for some procedures. So for example, the second intercostal space is the site for needle insertion in patients with tension pneumothorax. And the fourth intercostal space is the site for chest drain insertion and posteriorly between the 7th and 8th ribs. So that's what the 7th intercostal space, just above the 8th rib, is the site for needle insertion for a pleural tap, which is called thoracocentesis. So those are the most important landmarks that we need to just keep in mind. And as you probably know, we have 12 pairs of ribs. Pairs 1 to 7, the costal cartilages articulate anteriorly with the sternum, and the costal cartilage for ribs pairs 8 to 10, the costal cartilages for those ribs, they articulate with the costal cartilages of the ribs just above them. And then you know that we have floating ribs, so these are pairs 11 and 12, and they're called floating ribs because they don't articulate, they don't have any attachments anteriorly, and they can actually be felt posteriorly and laterally. So anteriorly, the apex of the lung actually goes 2 to 4 centimeters above the clavicle. And then the lower border of the lung, so if you're looking from the anterior side, mid-clavicular, it's around the sixth rib. And then if you're looking mid-axillary, it's around the 8th rib. And that's because it's not straight like that, it kind of goes, it slants downwards like that. And posteriorly, the lower border of the lung is around the level of the 10th rib. And obviously, the lower border goes down when the diaphragm contracts during inspiration because that pulls the chest cavity downwards. So that pulls the lower border of the lungs down. So as we all know, the right lung has 3 lobes. So the right upper, right middle, and right lower lobe. The left lung has only 2 lobes. So we have the left upper and the left lower lobe. So talking about the bronchopulmonary trachea, so the trachea splits into the left and the right main bronchi. So the right bronchus, main bronchus, is actually shorter and more vertical than the left one. So this is why aspiration pneumonia is more common in the right lobes of the lung. And that's because, again, as I said, the right main bronchus is more vertical and shorter compared to the left one. Then they split into the lobar bronchi and then segmental bronchi and then bronchioles, and then to the tiny little air sacs called alveoli. So alveoli, these are the sites of gas exchange. So this is where gas exchange actually occurs in the lung. We have 2 pleural membranes that separates the lung from the rest of the thoracic cavity. So we have the visceral pleura, which actually lines the outside of the lung. And then we have the parietal pleura, which lines the pleural cavity along the inner surface of the rib cage and the upper surface of the diaphragm. So the visceral pleura has no sensory nerves, whereas the parietal pleura, so the one on the outside, it's richly innervated by the phrenic and the intercostal nerves. And actually, the irritation of the parietal pleura causes pleuritic pain on inspiration on patients with pericarditis or pneumonia, for example. Just to quickly go over what happens during a normal quiet breathing. So the first thing is that the diaphragm contracts. So the diaphragm is the main muscle for inspiration. So it contracts, and what that does, it expands the rib cage inferiorly, and also the chest wall expands outwards. So this increases the volume of the thoracic cavity. So an increase in volume means a decrease in pressure. So that means that the intrathoracic pressure drops lower than atmospheric pressure. Therefore, the air on the outside goes into the lungs. Yeah. And then expiration is more like a passive process. So the diaphragm recoils, so it relaxes, and that obviously shifts the lungs back upwards, and that again reduces the volume. So decrease in volume means increase in pressure. So what happens is that air now goes out from higher pressure to lower pressure. So normal breathing is quiet, it's easy, and it's oftentimes inaudible. But during exercise or during certain medical conditions, you might see other accessory muscles being recruited. And for instance, the scalenes and the sternocleidomastoid muscles might be recruited and might be visible when the patient is putting more effort into breathing or when they are struggling to breathe. Right, so moving on to the most common concerning symptoms. Firstly, chest pain. So chest pain could have, multiple causes. It could be cardiac, it could be pulmonary. Actually, it's good to investigate further, to explore other extrathoracic causes like musculoskeletal pain or GERD, or even anxiety. So the lung tissues, they don't have pain fibers. So the pain is actually coming from the irritation or the inflammation of the parietal pleura lining the lung. The second most concerning symptom is dyspnea. Dyspnea is just a fancy word for saying shortness of breath. And to define this, it's just that unpleasant awareness that you're breathing is not enough for the level of exertion. So that's dyspnea. The degree of dyspnea plus the results from spirometry are important information to kind of determine the severity of some obstructive diseases, so like COPD, for example. But the thing is, there's really no way of quantifying dyspnea. Usually we try relate this with daily activities. So for example, you could ask the patient, how many flights of stairs can you climb before you pause to catch your breath, for example. Most patients would link their level of dyspnea with their level of exertion, but some patients, like anxious patients, may present dyspnea in a totally different way. So it might be a different set of symptoms with anxious patients. So they might come in and complain about episodic dyspnea. So they could have dyspnea during rest as well as exercise. And along with dyspnea, they might complain about other symptoms like paresthesias or hyperventilation, shallow and rapid breathing. The next important symptom that we need to know about is cough. So coughing, it's mainly a reflex action towards irritants in the larynx, in the trachea and bronchi. So for example, if you've inhaled pollen or dust, then the reflex response would be to cough it out, to get it out of the system. Causes of cough may include inflammation of the respiratory mucosa, the obstruction or the narrowing of bronchioles, maybe due to a tumor or a mass. It's really important to establish the duration of cough. So acute would be less than 3 weeks, subacute would be 3 to 8 weeks, and more than 8 weeks would be chronic cough. So we also have to ask the patient if it's dry cough or do they cough up sputum. So there's different types of sputum. So mucoid sputum, it's translucent whitish gray kind of color, and it's usually associated with viral infections and cystic fibrosis, whereas purulent sputum is like yellowish green in color, and this is usually associated with bacterial infections, so like a bacterial pneumonia, for example. Also have to ask the patient to describe like the smell, if it has any, and like the volume. So for instance, foul smelling sputum could be due to like lung abscess. Large amount of sputum also could be due to lung abscess or like bronchiectasis, and really thick sputum could be due to cystic fibrosis. So ask the patient to quantify how much he's coughed up. We can ask, how much do you think you've coughed up in the last 24 hours or in the last 12 hours? And we also have to ask for any other associated symptoms. So if the patient is complaining with fever as long as a productive cough, then it might point towards pneumonia. If the patient complains with wheezing as well as the cough, then maybe asthma. So the next common concerning symptom is hemoptysis. So hemoptysis is coughing up blood. So we need to distinguish this between vomiting blood. So blood originating from the stomach is usually darker and usually comes out with food particles and stuff like that. But in hemoptysis, the blood could be mixed with like phlegm or sputum. Again, when the patient is complaining with hemoptysis, we need to establish what they were doing, how much blood they've coughed up, and other associated symptoms before we can confirm any sort of diagnosis. And finally, daytime sleepiness is also another concerning symptom. So this usually points towards patients with sleep apnea. So this is defined as more than or equal to 10 seconds of like breathing cessation, followed by awakening and the patient is like gasping for breath. They can also have morning headaches and obviously sleepiness during the day. Moving on to health promotion, we need to first of all counsel patients about smoking. So we need to use techniques like motivational interviewing, and if the patient wants to change, then we need to emphasize the importance of quitting and like what health benefits it would bring them if they do stop smoking. So for example, just after stopping for a year, the risk of cardiovascular events and death is cut by half, which is quite significant. Also, the risk of stroke actually decreases to a similar level to that of a non-smoker after 2 to 5 years of quitting. And finally, which is actually a really, really big benefit, is after stopping for 10 years, the smoker's risk of lung cancer is cut by half. So the second strategy for health promotion is immunizations. So we have vaccinations for influenza virus, but as we all know, influenza virus quickly mutates. This is why we have to have it like annually, and each year the vaccine actually contains 3 to 4 different strains of the virus because it mutates that quickly. And it's recommended for anyone over the age of 6 months. So we also have vaccine for streptococcal pneumonia. So this vaccine is offered to everyone over the age of 65. This is also recommended for anyone between the ages of 2 to 64 who have chronic illnesses which would make them more susceptible to contracting this pathogen. This is also recommended for any adult who has asthma or is a chronic smoker.